Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons, the University of Utah, Wake Forest University, or the institutions of any of our guests. So today we're very excited to present an episode on SDSI ASES Fellows Day. So this is a subcomponent of the San Diego Shoulder Meeting in which current ASES Fellows get a chance to highlight their research, and there's a great program that is put on that also provides them, hopefully with some content to help them as they embark on their careers. To discuss, we've invited Andrew Sheean, who actually planned the entire program, and he's going to tell us about that part, and Dr. Waterman has conducted an interview with him. And then afterwards, we invited two fellows that presented their work, and they're going to talk about their work and the things they learned and the things that hopefully we can learn from their work. So I'm hopeful that you'll enjoy this episode in which we give you just a taste of all the great things that happened at ASES Fellows Day and all the great things that are happening in our training programs.
Today, we're pleased to have Dr. Andy Sheean on the podcast. Dr. Sheean is, at least for now, a lieutenant colonel in the U.S. Air Force, and he's stationed at San Antonio Military Medical Center in the Department of Orthopedic Surgery. Andy, welcome to the podcast.
Thanks for having me, Brian.
First, I definitely want to commend you for all your incredible accomplishments while in the military. But more importantly, I want to congratulate you on your upcoming transition to the University of Wisconsin. I know it's an exciting time for you.
I appreciate that, Brian. It's been a good run for us down here in San Antonio. We've made a lot of great friends. It's been a tremendous clinical practice. I really appreciate my practice partners down here, and as you alluded to, very excited for the next step in the move to Madison, Wisconsin.
Yeah, that's amazing. Congratulations on all your accomplishments. It's really cool. And more recently, you've also served as one of the co-chairs for the ASES Fellows Day at the 42nd San Diego Shoulder Course in Coronado Beach, California. Tell us a little bit about that experience.
So my involvement in Fellows Day started 5 years ago, and all the credit to Doctors Albert Lin and Robert Hartzler, who got me involved in the planning and execution of this meeting. And it's really evolved for me into something that I look forward to, and it's really been a great honor of mine to participate in this capacity. I've been really impressed with the extent to which the ASES devotes so much time and energy into mentoring and developing the next generation of shoulder and elbow surgeons. And I think that Fellows Day is really a conspicuous demonstration of that fact. And so this was my last year on the committee, and I was joined by Eric Wagner from Emory University, who did a fantastic job with the other program committee members and the ASE staff. And I think we really put together a great program that was beneficial for the fellows from the standpoint of presenting them with an opportunity to present their great research, but also we complemented that, and we were intentional with how we put the program together in terms of providing educational content, but also a lot of early career mentorship through panel discussions and pearls of wisdom type presentations.
Yeah, and I want to go there next because you really had an interesting mixture of content within this year's program. Tell our audience how you arrange these things, and why did you think these types of sessions are helpful to the current fellows?
So it's been an evolution, admittedly, over the last several years. The program itself has always featured fellows research, and that continues to be the cornerstone of the program. In recent years, we had supplemented that scientific program with case-based discussions and panel discussions and just conversations pertaining to clinical controversies. And over the last several years, we've pivoted away from that direction a little bit. The San Diego Shoulder Institute meeting, as you are eminently aware of, is a top-notch program that features many of those types of talks, clinical controversies and decision making and such. And so we wanted over the last 2 years to focus it a little bit more on the types of things that were not in the SDSI program, things pertaining to early practice management, difficult issues that early practice surgeons might find themselves involved with. And we wanted to change the focus of the program in that respect. And I think we succeeded.
No, I thought it was incredible. I found myself taking notes. I mean, you had a great list of speakers. You had Joaquin Sanchez-Sotelo, you had Larry Field in kind of this more senior role. And then you had these panel discussions that were led by Serena Namdari and OK Anakwenzi, and then small group breakouts with table discussions to follow. Maybe you could share some of your key takeaways from this more non-traditional content.
I think that for our panelists, I was really struck by the measure of candor and humility with which everybody spoke, and I think it reflects the extent to which that ASES surgeons are truly interested in molding and mentoring and guiding the next generation of shoulder surgeons. I think that the extent to which that Serena's discussion pertaining to early considerations on how to set up a practice and how to manage your finances, I think spoke to that theme. I think that OK's candor discussing how he and other panelists went about negotiating their approach to health and wellness early in practice. I think all of those things taken into consideration, I think really demonstrated exactly what it is that Eric and I were interested in, which was providing or supplementing the scientific program with some enduring lessons that I think hopefully our fellows are going to take with them there as they wrap up their fellowship training here in the next 6 weeks and embark upon their journey as newly minted shoulder and elbow surgeons.
Yeah, I would say the modern day litmus test of success of a given slide deck is how many phones are pulled out to take shots of the screen. And I saw plenty. I mean, it really was great content.
Absolutely.
Who are the target audience for this? Is it folks across the full spectrum of upper extremity, shoulder, elbow, and sports fellowships, or is it those just in shoulder, elbow? Just to clarify for our audience.
I think it's the former. I mean, admittedly, I'm a fellowship trained in orthopedic sports medicine, and that being said, the ASES has welcomed me with open arms, and so I think that reflects the broad engagement and target of the day to provide content that's relevant to surgeons that are getting training in shoulder and elbow surgery and in orthopedic sports medicine. There's, as you well know, there's a significant amount of overlap between those two subspecialty focus areas and domains, and I think that the program itself has lent itself well to being able to provide content that's relative to a wide array of surgeons and backgrounds and trainings.
Yeah, and that's my understanding as well. As Buddy Savoie was considering this in its inaugural session, I think it was in 2017, he really wanted to try to find a way to engage the next crop of leaders within ASES and the shoulder community. And I think this is the perfect forum for that. Arthroplasty, you have fracture care, you have arthroscopy and reconstruction all under one roof. And I thought that was a great way to highlight it. Additionally, the one of the primary focuses, as you alluded to, has been to allow for fellows to present their research, both in poster and form, and then also from the podium. And the highest rated presentations are inevitably given awards, and they're named in honor of a couple giants within our field, Bob Cofield and Rich Hawkins. Who were the winners and what were their projects, if you don't mind sharing?
Yep. So the Hawkins Award, which every year acknowledges the best poster, went to Claire Hayes for her study on the influence of positive cultures on aseptic revision after failed shoulder arthroplasty. And the Cofield Award for Best Oral Presentation and Podium went to Hayden Schuette for his study on predictors of revision surgery and complications after intramedullary nailing for proximal humerus fractures.
It's amazing to see the benchmark of quality that has continued to show up at these meetings over the years. And I, like you, have benefited from coming into this closed forum in order to engage in these somewhat intimate discussions. What would you like to see in the future of the ASES Fellows Day?
So endurance in one word, really. I think that as we've discussed, this is, from my perspective, a really, really important, valuable meeting for fellows every year. It's always circled on my calendar, and it'll continue to be circled on my calendar going forward. I think that it provides fellows with an opportunity to get their research out and some time at the podium, and for the ways in which we've already discussed, and the ways in which that the program continues to evolve. Hopefully it's something that they can walk away from with some knowledge as it pertains to, the state of the art, but also some real pearls and things that they can take with them as they start their practice, and all of the kind of the non-clinical type things and topics that we've mentioned here in this conversation.
Yeah, and I really like the technical pearl aspect. I was fortunate to be able to participate as well, but really I was just leaning on the experience of Larry Field, who's taught me a lot about repurposing of the biceps for centralization, for biceps SCR, for anterior cable reconstruction. And I think for our fellows out there, it's important to realize that we can glean a lot of lessons learned by reaching across the different programs, and these forums are certainly conducive for that.
Yeah, no, I really enjoyed your talk. I thought it was timely. I think that we, continue to struggle with how best to manage patients with massive, quote unquote, irreparable rotator cuff tears. And I thought that your technique and your video presentation was excellent. Steve Parada also did a great job providing his technical pearls for humerus exposure and shoulder arthroplasty. And so those were both really, really important contributions to the program and to the agenda. And I appreciate your contribution in that respect.
Well, as you reflect back on your fellowship year and you want to offer one parting word of wisdom to those fellows that in a short month are going to be starting their first year of practice, maybe I'll give you the final word.
So I think that it's important to approach this next chapter in your life with the requisite amount of humility and enthusiasm. And as Fellows Day demonstrates, the ASES is an extraordinary resource for surgeons at all points in their training, but certainly for early career surgeons. And I would encourage the fellows that are getting ready to go out and start their independent practice to take comfort in that fact, and take comfort in the fact that by virtue of completing their fellowship training, they've been exposed to a network of surgeons that are invested in their futures in an enduring way. Have a low threshold to reach out to your mentors, have a very low threshold to reach out to your co-fellows. You're not on an island. It's a group of extraordinarily talented individuals, and everybody, without exception, is interested in your success. And so take advantage of that fact and enjoy the ride.
Well, Andy, always so artfully stated. I really appreciate you taking the time amidst your move and all the other things that we have going on in the world. Thank you for donating your time today.
Thanks, Brian, and congratulations to you and Peter Chalmers for your work on the ASES podcast. You guys are putting out amazing content, and it's can't miss media. So congratulations.
Yeah, thanks for those kind words. I just want to commend you and Eric Wagner for leading the charge on what really has been such an important part of the San Diego Shoulder course since 2017. I think it's always meaningful to reinvest in the next generation of talent. You've certainly done that with your great program. So thank you for being on as a guest, and hopefully this is the first of many as you make the transition to civilian life. Congratulations.
Thanks, Brian.
Perfect. Thank you. That's about all the time we have today. We look forward to seeing you on a next episode in the near future. Bye.
So to highlight all the great research that was presented by fellows at the ASES Fellows Day at the San Diego Shoulder Course, we've invited two fellows onto the podcast as guests. Both won awards for their research at Fellows Day and should be proud of their work and accomplishments. First, we have Dr. Hayden Schuette, who is just now finishing his fellowship with Armand Hatzidakis and Ben Sears at Western Orthopedics in Denver. Hayden, welcome to the podcast.
Thanks for having me, Dr. Chalmers and Dr. Waterman. It's a pleasure to be on.
Now, Hayden, you presented your work, Radiographic Predictors of Repeat Surgery and Post-Operative Complications in Proximal Humerus Fractures Treated with Third-Generation Intramedullary Nails. Tell us what inspired you and your colleagues to do this work.
Yeah, well, thanks. So I first need to give a shout out to the previous fellow, Gage Griswold, and this was kind of his idea. When he was a fellow last year, he published on the outcomes of 2-part versus 3- and 4-part proximal humerus fractures treated with intramedullary nail. And I think in that study, he got interested in trying to figure out, well, what radiographic predictors related to the nail position and really the fracture reduction may influence these complications. And so this was something that he kind of came up with at the tail end of his fellowship, and we've kind of continued with and are hoping to get it published here shortly. But I think really, we know with plating, we know some of the pitfalls with plating, whether it be plate position or screw position, calcar support, things like that. And if you're aware of those factors, you can, be conscious of it during surgery to avoid these pitfalls. And so that's really what we were trying to figure out with this study and this paper.
Yeah, that's great, Hayden, and I appreciate the shout out to Gage and your fellowship crew. That's awesome that you have continuity there. What was your study design, main clinical questions, and kind of primary endpoints as you scripted this out?
Yeah, so the primary endpoints were post-operative complications, specifically looking at avascular necrosis, post-operative glenohumeral arthritis, and then the need for reoperation, whether that be an arthroscopic reoperation, a revision, or a conversion to arthroplasty. So that was really the main outcomes that we were looking at. And as far as the design, this was a retrospective study based on Western's experience over the last, it was between about 2009 to 2022. They had prospectively kind of collected patient outcomes in database. So we used that database to complete this study.
And then what did you find looking back through the database?
Yes, so overall, when we looked at the complication rates, the most common complication that we found was the need for reoperation. That was about 20% of patients. And mind you, this was at, an average follow-up of about 3.5 years. So, fairly decent follow-up for trauma literature. So we found that, the most common complication was reoperation, and of the 21% of patients who needed reoperation, the majority of those, about 15%, needed an arthroscopic debridement for stiffness and then plus or minus removal of proximal screw. And most often that can be, the lesser tuberosity screw is a little proud. That tends to be one of the pitfalls that we've seen. And so that tends to be the most common screw that's being removed. And then when we looked at conversion to arthroplasty, there were about 7 patients in our 73 patients, so just under 10%, who ultimately got converted to either reverse or anatomic arthroplasty. And then 1 patient, so just at about 1.5%, who needed a revision or AF. And then, that was the reoperation cohort. And then we looked at avascular necrosis. We had about 8 patients who developed avascular necrosis. And then 5 who developed post-operative arthritis of the glenohumeral joint. So those were kind of the overall findings, but really the point was to look at those radiographic predictors. And so Gage had kind of come up with these 7 different predictors, related to fracture reduction, but also nail positioning relative, to the humeral head or the height of the nail and different parameters. And so what we found when we looked at which of these parameters actually affected these complications and outcomes, we found two different things. The first was that we found when you had calcar overhang, specifically medial calcar overhang, this was correlated with, an increased need for reoperation, specifically conversion to arthroplasty or the revision ORAF, and then also the development of avascular necrosis. And then the second finding was that a poor reduction on the lateral or on the axillary lateral radiograph was associated with glenohumeral arthritis. So those were the two main findings as far as our radiographic evaluation went.
One of the classic things you commonly ask with any research is, how will this change your practice moving forward? Maybe you can share your own personal experience and then that of your fellowship attendings.
Yeah, I think, when we nail a lot of different other long bones, you think about tibias or femurs, sometimes you get away with the nail kind of doing the reduction for you. This is, and in my experience, this year with, HOTS and SEERS and also looking at all these radiographs, that's not something that you can really rely on when you're nailing proximal humerus fracture. And so I think it's really important to make sure you get the reduction correct before you get your starting point and start to, instrument with the nail. And so the majority of times for us that can be done percutaneously. But, if you do need to do an open approach, I think there's still utility in that. Even if you're going to nail, a lot of times we think when we're doing an open approach, we end up doing a plate, in different parts of the bodies, but I think there is a role for open fixation, intramedullary nailing, proximal humerus fractures. So I think that's the biggest thing, is just making sure you get the correct reduction and the right reduction, and don't overly rely on the nail to do that for you.
Now, Hayden, you're at a center that's doing, it sounds like, a relatively high volume of nailing. It sounds like you had a couple of patients that were converted to arthroplasties. Have you been in any of those cases? Like, what is the difficulty you encounter in converting a nail to an arthroplasty? I think we've all been in the case converting a plate to an arthroplasty. We know that's not an easy case. I guess maybe the question I'm seeking to ask you is, would you rather convert a nail to an arthroplasty or a plate to an arthroplasty?
Yeah, that's a good question. I'm thinking back, I don't think I've had to convert one this year. Thankfully, just kind of the luck of the draw, I guess. But, I think the biggest issue that we've seen when we have converted plates or even, malunions that have been treated non-operatively is, these varus malunions and managing the tuberosities. How do you get your stem down in the canal if you have a varus malunion of tuberosity, and how do you manage that? Do you perform an osteotomy and then rely on the osteotomy healing? Do you try something with, off-label with a stemless implant or maybe a short implant? There's different things that I think have been done. But I think that's the most difficult problem, is when you're dealing with a non-union, a malunion. As far as taking out a plate or taking out a nail, you can always bypass the screw holes and things like that with longer stems to hopefully decrease the chance of periprosthetic fractures, but that's also something to consider as well.
Yeah, Hayden, and since you opened it up a little bit, I'm curious your concise pearls, because you've had a high volume of those, these nail constructs. What are your pearls for obtaining that appropriate reduction so it hopefully decreases the risk of adverse outcome?
Yeah, the way Dr. Sears and Dr. Hatzidakis have taught me is it all starts with patient positioning. We like to do this in the beach chair position. We use an arm holder and we put the arm in neutral, and then you don't move the arm, because if you move the arm throughout the case and mess with the rotation, that can that can mess with your imaging and you're looking at different perspectives. So I think that's number one, is your setup, having the right setup. And then most frequently we were doing this percutaneously, with either a small Cobb elevator or a Joker elevator, and you're just making sure that you get the elevator down into the fracture site and kind of towards the calcar. And a lot of times we're ending up kind of doing this, Hots kind of talks about this head lift maneuver, where you're lifting more so than really levering, because if you lever, you can end up cracking the shaft or something else that you don't want to do. So you're really trying to lift the head most often out of varus. And I think, over reducing it sometimes a little bit into valgus can be helpful as well. And then, the thing that I've found harder to judge, and that Dr. Sears kind of talks a lot about, is really, manipulating the version as well. And so that just, I think, takes a lot of experience understanding how the head is mal-rotated and looking at your x-rays and trying to get the version correct. And so again, these guys who do a lot of them, they can, over time, make small adjustments, all with just a cobber joker. But, if you're struggling, there's no shame in opening up as well.
Now, it's interesting to me, Hayden, that the most common reoperation was an arthroscopic debridement. Tell me, is that mostly about removal of hardware and you're just taking a look at the joint at the same time? Like, what were the main indications there, and how do we connect that with this kind of medial calcar overhang?
And that is stiffness. It tends to be stiffness, and so I think they're pretty aggressive in some patients. We know stiffness is a problem with plating, it's a problem with nailing, it's a problem with non-operative management, and I think they're a little bit more aggressive in feeling like that they can make these patients better with an arthroscopic capsular release. So there may be a lower threshold, in my opinion, for them to do that procedure. And with that, a lot of times you end up, if you're kind of freeing up the deltohumeral interface, you end up having access to some of these screws, and you may see that they're a little proud, and so you can remove them. So I think that is probably their reasoning, and what I've kind of learned over time with them. As far as the medial calcar overhang and how it relates to reoperation, so we looked at, in general, it is associated with reoperation, but we actually ran analysis and tried to look at just arthroscopic, and it was not significant. So if you take out the patients who had arthroscopic procedures, or I guess I'd say if you compare the patients who had arthroscopic procedures compared to those who had no reoperation, it wasn't predictive. So it was really where it was most predictive was for the conversion to arthroplasty and the revision ORAF. But I think the data, if you put them all together, it still comes up as significant overall for reoperation.
Well, Hayden, I definitely would congratulate you on a great publication or future publication and great presentation. It definitely stood out in the audience of really a bunch of great projects. What's next for you in your career?
Well, thank you. So I will, I guess, gosh, we're getting close here. In about 3 weeks, we are moving to Minnesota, where my wife's from, and I'm going to be joining Practice Twin Cities Orthopedics, big private group, and I'll be in kind of the western Minneapolis suburbs. So we're excited to get back home to my wife's hometown and have a little family support for the kiddos. And I'm excited to start my practice. It's certainly I'll be joining a private practice, so I'm going to have to build my shoulder and elbow practice over the next few years. But I'm looking forward to that challenge and hoping that in a few years I can be like a lot of you guys and some of my mentors and doing just shoulder and elbow.
Well, there's just enough icy terrain, I think, to keep you busy with proximal humeri. So don't you worry about it.
Yes, yeah, and I enjoyed the trauma and a little bit of hand and knee here too. So I'm sure I'll find myself staying busy for a while. But yeah, we're excited. Definitely a lot of ice up there though.
Well, Hayden, on behalf of Peter and I, thank you so much for coming onto the podcast to discuss your work. And again, we just congratulate you on your work and all the amazing things that we know that are to come with you after fellowship and through the ASES. Please keep in touch and continue to advance this discourse on intramedullary nailing.
Well, thank you, Dr. Waterman and Dr. Chalmers, for having me. It's been a pleasure to kind of talk about our research and spread the good word of proximal humerus nailing.
So next up is Dr. Claire Hayes, who's just now finishing her fellowship with Dr. Eric Ricchetti at the Cleveland Clinic. Claire, welcome to the podcast.
Hi, thank you so much for having me.
Now, Claire, you presented on your work the influence of positive cultures on aseptic revision for failed shoulder arthroplasty. Tell us what inspired you and your colleagues to do this work.
Yeah, so at the Cleveland Clinic, we definitely see our fair share of revisions, outside referrals, just a large cohort of, all sorts of primary and revision patients that come to see us. And we actually have a large database of both primary and revision shoulder arthroplasty patients. So this kind of gives us a large pool of patients when we have an idea to kind of have this large pool of patients, big database that can help get this kind of research off the ground. I was interested in this when I started, just from seeing how many, both septic and aseptic revisions we do. And I don't have to tell anyone this, but in the shoulder world, we aren't exactly sure what to do yet with patients, whether they're a known septic revision or a presumed aseptic. And so I was just interested in knowing, these patients that you go in thinking they're aseptic and then they wind up having these unexpected positive cultures, and then what that means for them in the long term. There's already been some studies published that shows really no difference in outcomes, but we just have such a large cohort of those patients. We wanted to see what we would see amongst our patients.
And during this time period, were all revisions cultured, or was there some selection as to which ones got cultures and which ones did not?
So out of the entire cohort, not every revision was cultured. The ones included in this study, we only included the ones that did get cultured. But looking through all those patients, the ones that didn't get cultured, it tended to be your instability within 3 to 6 months type patients, periprosthetic fractures, again, within that shorter time period just after having surgery. But in general, any patient that came from an outside facility or, didn't have a reason other than, just kind of pain to undergo a revision did get cultures taken in the OR.
So what did you find with regards to those cultures?
Yeah. So overall, we had about 20% having at least 2 positive cultures of the same organism, which is, kind of falls roughly in line with other published literature. The more interesting fact was just the demographics of those patients. So our patients that did have 2 or more positive cultures were much more significantly male and younger, which we know those are the patients that are more likely to be infected with C. acnes anyway. And C. acnes was the most cultured bug that we did find. So that wasn't necessarily a new finding, but it did, just kind of reinforce some things we already know about these patients. And on top of that, our preliminary data does not show a difference with regard to outcome. The only outcome measure that did have a significant difference was the ASES score. However, those patients that had 2 or more positive cultures, they only scored about 8 points higher, which is less than the NCID for ASES, which is 10 points. So not particularly clinically significant. So, really overall, this study so far has kind of fallen in line with other studies published on this data. But I think the more interesting thing to come from this is just learning, what to do with these patients in regards to management, and having a more informed discussion with them. Because I think the most interesting finding that we had was just that the complications in those patients that did have 2 or more positive cultures was significantly higher than complications for patients that didn't have those positive cultures. And it was more, the complications were higher with the antibiotic administration. These patients were on IV antibiotics and they were on a much longer course of antibiotics too. So they really had higher morbidity because of the antibiotics we were giving them. So for me, what I'm kind of taking from this is the question is really in the management, and it's, do these patients that have these positive cultures with C. acnes and other non-virulent bugs, do they need these intense IV antibiotics in order to treat them?
Yeah, I think that's a very interesting insight. I mean, it's interesting to me that there's not really an association between these unexpected positive cultures and outcomes. I mean, to me, this This connects with this larger conversation that I think we're beginning to have in our field about the role of cultures generally in diagnosis. They may actually not be that helpful in the diagnosis of
Mhm.
periprosthetic sepsis. So I guess my question for you is, I mean, is there a future in which we stop collecting cultures?
Yeah, I mean, I think that's certainly a possibility, because, again, it goes back to those, complications with the antibiotics. I mean, are we over-treating patients, especially these, young males who we know just have a higher burden of C. acnes anyway, and they may just be, their body can kind of coexist with that bacteria, anyway, and they may, do okay in the long run. So I do think that is kind of where the research should be going at this point because, doing literature search for this data again, looking at all the studies that have kind of been published on a similar topic, we all see the same thing. We see a roughly 20 to 30%, maybe a little less, rate of these positive cultures, most commonly these non-virulent bugs. And in the end, those patients don't do any worse than patients without those positive cultures.
So tell me, you're headed into practice. It sounds like you're going to join a group where you'll be doing some shoulder arthroplasty, I'm sure some revision shoulder arthroplasty. What's going to be your practice standard? Like when you go out into
Yeah.
practice, you have a patient who comes in, say, for glenoid loosening, you're going to need to do a revision. Are you going to get cultures on that patient?
hmm Yeah. Tricky question. I think if it's a patient, that comes from an outside hospital with loosening, I think I would. Which again, I may have bias just based on where I've trained. Dr. Ricchetti and both Doctors Ho and Intezari are all very good about taking cultures for pretty much every case, every revision case. Um, so I think in that situation with loosening, I certainly would. Um, and again, any outside patient, I think I would just be more biased again towards taking cultures just because, I wasn't there for the first surgery. But for my own patients, my own revisions, I think if it's for which are, a straightforward instability, periprosthetic fracture, something like that, I don't see myself taking cultures. But loosening of any kind, I would lean towards taking cultures.
Yeah, I think those are great insights for our listeners as we head into a future in which, I think there's a reasonable argument to be made from this paper that maybe these cultures are not as helpful as we think they are. They don't determine
Mhm.
outcome, and maybe there's complications associated with them. But I think ultimately this like all of our other research really points the way that we need better diagnostic tests for infection. And there's still a great need for us to have some sort of other point of care test that, whether it's DNA based or antigen based or, based on some sort of host response, can
Mhm.
better determine which bacteria we're culturing are pathologic and which are commensal or contaminant or other.
Yeah. Yeah, I definitely agree with that. And it's, we used the ICM criteria when we were, pulling data for the study. And of course, any patients that, were a definite or probable PGI were excluded. But even in those patients that had, unlikely infection or possible, the ESR and CRP and other factors between these two groups really were not different. So yes, I think just like the management is murky, the diagnosis is even murkier. And it's interesting. We're going to be hearing about the proceedings from the most recent ICM consensus meeting. So I think that will hopefully shed some light, and that if there were some new, groundbreaking things discussed, and we'll see what comes of that.
Yeah, we're hoping once there's publicly released data, then we'll have to have Eric and Jason Sue on, and they can fill us on what the
Mhm.
conversation was in Istanbul. Well, thank you, Claire, for coming on. This has been really helpful to have your insights. Congratulations on your work and graduation from fellowship, and we wish the best of luck in the future.
Thank you so much, Dr. Chalmers. I appreciate the opportunity.
Well, that's the entirety of the episode. A big thank you to all of our guests. For all of our Shoulder Number listeners out there, don't forget to subscribe, and we will see you next time.